So we need to do some further baseline investigations now to work out exactly what the treatment options will be for you. The first thing that we like to do in this situation is to take a further set of biopsies from the area in the bladder where the tumour was removed, and this is to try and make sure that the tumour definitely isn't in the muscle wall of the bladder. And we know from our experience here at Addenbrooke's that approximately 1 patient in 5 will have been understaged by the original operation. And by that we mean that the tumour will be in the muscle wall of the bladder despite the results from the first operation.
Yeah.
So in this scenario we would always recommend that we do what's called a repeat resection of the bladder tumour to be certain that the muscle wall isn't involved.
I came in the first week of January for some more biopsies to be taken, and that pattern continued for a good sort of month at least.
The risk of progression is usually estimated over a period of 5 years, in the absence of any active treatment other than telescopic surgery. For patients with so-called PTAG3 disease, which is confined to the surface lining of the bladder, progression occurs in between 15 and 40 patients out of 100. For those with tumour in the connective tissue layer of the bladder, PT1G3 disease, it occurs in up to 50 patients out of 100. And for those with aggressive cancer cells spreading within the surface lining, known as carcinoma in situ, it may occur in as many as 70 patients out of 100.
The other things that we like to do in this situation is to get a bit more information about the outside surface of the bladder. So when we look in with the camera, we can see what's going on in the lining of the bladder, but we also like to see what's going on outside the bladder. So we would like to do a scan called an MRI scan to look at the outer surface of the bladder and also to make sure there has been no spread of the disease into the lymph glands or into organs outside of the bladder. So you will get a separate appointment through the post for that scan.
Okay. Okay.
Okay.
Yes, sounds good.
So when we talk about progression, what we mean is involvement of the deeper layers of the bladder, and in particular we're talking about involvement of the main muscle coat of the bladder. So the development over time of involvement with tumour of the main muscle coat of the bladder. And the reason that's significant is that when there is involvement of the main muscle wall of the bladder, if you take 100 patients like that, we know that between 20 and 25 of them will also have tumour in the lymph glands around the bladder. And when that happens, the chance of cure falls, usually quite sharply. The risk of involvement of the lymph glands overall in patients who have non-muscle invasive bladder cancer is that between 5 and 10 patients out of 100 will have involvement of the lymph glands by tumour. In terms of options for treatment of cancer not involving the muscle wall, non-muscle invasive bladder cancer, 2 options which are used in other cancers and also used when bladder cancer does involve the muscle wall of the bladder, they're chemotherapy and radiotherapy. But when the cancer doesn't involve the muscle wall of the bladder, they're not felt to be suitable treatment options. And that leaves 2 other options. One is surgery. That surgery to remove the bladder, and that's called cystectomy. And the other is use of a vaccine, and that's called BCG. And the vaccine is put into the bladder in liquid form, and that's another way of treating non-muscle invasive bladder cancer.
There is more information on surgery to remove the bladder in the chapter on treatment of invasive bladder cancer. BCG is a type of liquid vaccine therapy that works by stimulating your body's own immunity to destroy cancer cells in the bladder. BCG, which stands for Bacillus calmette-guerin, is a bacteria from the same family as the tuberculosis or TB bug, but it's not the same as the TB bug, so you cannot catch TB from this treatment.
So what we'll do is we'll empty your bladder. The BCG solution I make up, and it's about 50 mils. That's all it is 50 mils. And using the same catheter, I then put the BCG solution into your bladder, and ideally you should hold it in your bladder for 2 hours, because that's where you get the maximum treatment.
Oh boy, yes, okay.
The initial treatment was a session of 6 installations, and then followed by a further 7 treatments. And the installation of the BCG and the holding of the fluid for 2 hours didn't pose any difficulties as far as I was concerned. The unpleasantness started passing water. It is sometimes painful, particularly when debris is being ejected.
Because the vaccine is live, there are a few precautions to take. You will find details of these on the website. Most people have some mild side effects after BCG treatment, but they tend to reduce over a couple of days.
So common side effects are what they say common. So you could get urinary frequency, you could get urinary urgency, you could get bladder discomfort, you could get blood in your urine, and you could get debris, because it sort of causes a chemical cystitis. So the best way we advise you to deal with this is once you get home and you've done those 2 hours, you've had the BCG in your bladder for 2 hours, and I'll explain to you what happens then if you drink more while you're on this programme, that will help you. And sometimes you can get flu-like symptoms, and when we say flu-like symptoms, we don't mean coughing and sneezing. That means you've got a cold or something similar. What we mean is, have you got a temperature, and have you got generalised aches and pains? So the best thing to do is, if that is you, is to make yourself comfortable and bring your temperature down. So we suggest that you take some form of analgesia that you might normally take. What would you normally take if you had a temperature and some aches and pains? And
I think my wife would give me Anodin.
That's fine. If that's what you take, that's fine. But take something so that you bring your temperature down. Otherwise you might get some shivering and some shaking and feel just a bit miserable. Mm-hmm. This can last up to 72 hours after your treatment.
I have discovered that one of the most important parts of alleviating any difficulties is to take plenty of water, and 4-hourly doses of 2 paracetamols. So usually what I do is to take 2 paracetamols before the treatment, and thereafter 2 paracetamols 4-hourly. And after the 2 hours of retention have been completed, I start taking a lot of volume in water. And I aim to drink at least 3 litres of water within the next 3 hours. And that certainly, in my opinion, has helped the situation.
For about 70 to 80 in every 100 patients who have just one form of high-risk, non-muscle invasive bladder cancer, at first checkup following a course of BCG treatment, their bladder has become clear of cancer. However, up to half of those who respond in this way will go on to get further bladder cancer. This means that the overall response rate to the BCG is about 1 in 3, possibly up to 1 in 2. If there is more than one form of cancer in the bladder, the overall proportion of patients whose bladder cancer does not return following BCG treatment can fall as low as 1 in 6. Most patients who have recurrent cancer after BCG can be offered surgery with a good chance of cure, although a small proportion, perhaps 5 out of every 100 originally treated with BCG, will have recurrence that is already too advanced for surgery to cure it. Surgery at the outset does therefore offer a slightly higher chance of cure, although this does not mean invasive treatment rather than the chance that BCG might be sufficient treatment.
Yes, as soon as I knew that I'd got this aggressive tumour, or that had gone, but it was a question of stopping it coming back again. But I didn't know at that stage whether I still had the option of BCG treatment, but I was weighing up if I had the option which I would go for. And initially my thought was, oh well, I'll have treatment. But then I came around to thinking, well, surgery is treatment as well. And I did a lot of reading on the internet, which I know isn't always a wise thing, but I pick and choose what I read. And looking at the prospects, survival statistics, the percentage of people who have the BCG treatment but still end up having surgery. And I felt really, however good the statistics were, no one can tell you whether you're going to be the one for whom the treatment will work or whether it won't. I was already unlucky enough to have this unusual tumour, so I didn't feel very lucky. I felt I wanted to go for the path that would give me best prospects. I didn't want to try the treatment and maybe end up still having surgery. So I think that was what brought me round to thinking that I would go for surgery even before I knew definitely whether I'd got an option or not.
They were hoping to remove more and more tumour as they were going along, but it was just growing back so rapidly that nobody can keep on top of it. So after a lengthy discussion, I decided that I needed a cure from this, and we all came to the decision in the end for my bladder to be removed as the best cure possible.
I weighed up the pros and cons. It's a very difficult decision to make. You've got the option of BCG treatment, which isn't guaranteed successful and potentially has unpleasant side effects as well. Or the surgery, which is risky, and you obviously then have to choose reconstruction or having the stoma in a bag. So anyway, I decided I would go for surgery. I didn't want to take the risk of it getting worse. So jolly drastic preventative treatment, but no, that was my choice. Have it done now while I was fit and could cope with it.
If your bladder cancer involves the muscle wall of the bladder, stages T2 to T4 disease, the treatments to consider are surgery to remove the bladder or radiotherapy using high-energy X-rays to destroy the cancer cells. You might already have had some treatment for early-stage cancer, or your cancer might have been found to be muscle invasive from your initial investigations.
I saw Mr. Turner again, and he said you have this option of chemo and then an operation. And that has the best results to do it that way round, or you can have radio, or you can do what you like. So, of course, you go for the best results.
It was suggested that I could have radiotherapy treatment, which, if you have that, even if it fails, at least you can have the operation afterwards. The reverse, if you have the operation, you can't have the radiotherapy afterwards, because obviously it's not there, the tumour's not there as such. So I said, well, I prefer the actual radiotherapy.
So I came back later and they did a biopsy, sent off for some tests, and it was the very aggressive one, so they had to get on with it. So I went and had chemotherapy, and then the surgery.
Muscle invasive bladder cancer means that the cancer involves the main muscle wall of the bladder, or goes through it and beyond it into surrounding structures. So in terms of treatment, some patients will be able to have chemotherapy, but then with chemotherapy or without, we then look at what we would describe as local treatment to the bladder. And there are two options there. One is surgery to remove the bladder, that's called cystectomy, and the other is radiotherapy, X-ray treatment or radium treatment. And the purpose of radiotherapy is to try to kill the cancer without removing the bladder. Now, whereas we know with certainty that chemotherapy helps, we don't know with anything like that certainty whether surgery or radiotherapy is more effective as a local treatment for cancer involving the muscle wall of the bladder. There is evidence to tell us how the two treatments work, but it doesn't help us try and decide which is more effective. And the views of different specialists differ. There has been a view that surgery may offer a greater chance of cure for those patients who are able to have surgery, but we don't know whether a greater chance means a slightly greater chance or a much greater chance, or actually no greater chance. And so we generally consider, for patients who could have either treatment, what the pros and cons of surgery and radiotherapy would be for that particular patient.
Radiotherapy is the use of X-rays to destroy cancer cells. Prior to receiving radiotherapy, the location of the cancer within the bladder is carefully identified using a CT scan. The radiotherapy X-rays are then targeted directly towards the cancer in a carefully controlled beam. This technique is called external beam radiotherapy.
I suppose the thought, first of all, of entering this big machine, which it is, which does make quite a whirring noise, etc. But, you know, there's nothing to it. It's, you're marked when they first see you. They actually put guide marks on you so they can line you up with a laser when you're in there. You lay back on this table, and obviously, depending, I assume, where it is, they actually then position you, then they'll come out, reposition you, and then just let the process run, which is only a very short, minimal time. So anyway, I went ahead with that, which was 20 doses of radiation, which it's a 10-minute process, of which really 2 minutes is the actual process, and the 10 minutes is actually, 8 minutes of it is actually lining you up. So you've got you in exactly the right position.
We use radiotherapy to treat bladder cancer, either on its own or after chemotherapy. Radiotherapy is quite successful at treating bladder cancer, but it will all depend on how far advanced your tumour is. For bladder cancers that have just invaded into the muscle wall, what we call T2 bladder cancers, the success rate is quite good. 70 per 100 patients will survive. If your bladder cancer has grown through the bladder wall or invaded other organs near the bladder, so it's more advanced, the success rate will be lower, somewhere in the range of 20 to 50% for every 100 patients treated.
You will go to the radiotherapy department every day for 6 or 7 weeks, usually Monday to Friday, with a break at the weekends. The treatment takes about 10 to 15 minutes, although you can expect to be in the department for a couple of hours. Afterwards, you will usually be able to go home.
After the radiotherapy ends, you then have to go for a CAT scan, but this doesn't happen until 3 months after you've finished, due to the fact they say that the radioactive treatment is still working and you may still get side effects from them, although I didn't. The CAT scan then showed, which is a movable X-ray they take, which is very accurate, didn't show any cancerous tissue left. I was then, after about 2 weeks from that, I then had investigating treatment with the scope to check on this, which they took a sample, and this sample, luckily after 2 weeks, came back as cancerous free. I then got to go for further investigation treatment every 3 months, which is an internal examination just to check on how you're going. But this continues normally for apparently about 4 years, and if you're free after that, you go back to 6 months, and then I think after that, about 5 years or 7 years, depending, you are then told that you're probably free. So I think the process is pretty simple and not a major thing to worry about.
Radiotherapy is quite high-tech these days and is directed very specifically at the bladder. So each day that you have radiotherapy, we ask you to empty your bladder first to make the target as small as possible. The smaller the target, the less side effects you will have. Side effects are related to either the bowel or the bladder because they get irritated from radiotherapy. Regarding the bowel side effects, you'll find that your bowels get a bit more loose. When you gotta go, and there may be a small amount of mucus or occasionally a small amount of blood mixed in with the stool. These side effects all heal up within 3 to 4 weeks of finishing radiotherapy. Regarding the bladder side effects, again, the bladder can get very irritated towards the end of radiotherapy, and you may have to pee more frequently. When you gotta go, you gotta go. And when you pee, it may sting a little bit, usually at the very beginning of the stream. We do find that cranberry juice can be very helpful for this, and these side effects also all heal up within 3 to 4 weeks of finishing radiotherapy. For a very small percentage of patients, some of these side effects can be more long-term. For men, there can be long-term side effects regarding erectile function, and for all patients, you can feel a bit tired after your radiotherapy, which can last up to 6 weeks after this.
You can get diarrhea, can be a side effect. You can get a burning sensation, the skin can redden, and obviously an irritation, but nothing untoward. It may upset your digestion apparently a bit, but as I said, as I never had anything of that, I mean, it's a bit difficult to describe anything. It was purely what I was told, but for me, nothing.
It is generally considered that removal of the bladder, called cystectomy, allows more accurate assessment of the extent of disease, as, in addition to removing the bladder, lymph glands around the bladder are also removed during the operation. This allows detection of any microscopic spread of cancer outside the bladder, which may not have been seen on pre-treatment staging of CT or MRI scans. We know that some patients whose cancer has spread this way to the lymph glands can still be cured by surgery. Thus, surgery is often thought to be more likely to lead to a complete cure than radiotherapy. However, specialists agree that the risks of surgery are significantly greater than those of radiotherapy. If your general health is poor, for example, if you had problems with your heart or you are overweight, these risks increase. The risk of death related to surgery is about 2 in 100, although it is higher in older people and those who have other health problems.
So whether treatment is going to be surgery or radiotherapy, we consider for all patients with cancer in the muscle wall of the bladder, muscle invasive bladder cancer, whether they could have chemotherapy. And the reason for that is chemotherapy has been shown to improve the cure rate for muscle invasive bladder cancer. And we can be pretty certain of that because we have what's called very high quality evidence to support the use of chemotherapy. But chemotherapy is not suitable for everybody. It's not suitable for patients who are older or whose general health is not so good. So we consider chemotherapy for everybody, but not everybody is able to have it. Whether or not chemotherapy is possible, some local treatment to the bladder is done, and that's either surgery, and that's called cystectomy, or radiotherapy. Now, unlike the evidence for chemotherapy, which is very strong and makes it very certain that chemotherapy helps, the evidence that tells us how good surgery is and how good radiotherapy is less strong, and we don't know whether surgery or radiotherapy is more effective. But we think that surgery is probably more effective in terms of cure. So most patients are offered surgery, provided their general health is good enough. Surgery certainly has more risks than radiotherapy, and if your general health is not good, it may be the case that the risk of surgery becomes sufficiently high that it's better for you to have treatment with radiotherapy than with surgery.
Chemotherapy is the use of drugs to destroy cancer cells. When given to help treat bladder cancer, these cancer-killing or cytotoxic drugs are given as a combination of different drugs, but always include a drug called cisplatin. Different combinations of chemotherapy drugs can be given, depending on whether you are treated as an inpatient or an outpatient. They are normally given directly into your bloodstream through a needle in your arm.
Some side effects are inevitable with chemotherapy, though the way they affect different people can vary greatly. Most side effects, though, are controllable with medicines.
Advice on what to do if this affects you is given on the website.
The white blood cell count can drop during chemotherapy. White blood cells are your body's main defence against infections, so if you show any signs of infection during your chemotherapy course, then you must contact us immediately.
If you start to feel unwell, shivery or feverish, or if your temperature goes up above 38 degrees Celsius, you should call the hospital immediately.
Chemotherapy can also cause the number of platelets to drop in your blood. Platelets are important in clotting your blood.
Look out for any unexplained signs of bleeding, like bleeding or bruised gums, red spots or rashes on the skin, bruising, or nosebleeds.
During chemotherapy, we also check blood for the hemoglobin level. If the hemoglobin level falls, this is known as anemia. Symptoms of anemia include breathlessness, feeling dizzy, and tiredness.
Other less serious side effects of chemotherapy can nevertheless be quite unpleasant. Feeling sick or actually being sick can start soon after your treatment and might last several days. However, your doctor can prescribe anti-sickness drugs called antiemetics to reduce this feeling and stop you being sick. You might not have much appetite, and you might have a sore mouth, a loss of hair, or feel very tired. For some women who haven't yet been through the change of life or menopause, chemotherapy can cause this to start early. Sometimes people may notice that their hair thins or falls out, which can be distressing. Your named specialist nurse will help you cope with these unpleasant side effects. There is also more information on the website on combating and living with these side effects.
Before any treatment is given, whether it's surgery or the radioactive treatment, you normally have chemotherapy, which the idea is to shrink the tumour. Apparently, when they're lucky, it takes it down by about 10%, which is a good start and helps in the, to prepare you for either the operation or the radiotherapy.
A day and a night of drips of this chemotherapy going into my veins, and I had to be in hospital for that overnight. And you felt, excuse me, very nauseous and just terrible.
In my case, it didn't really affect me at all, although probably the side effects of that were that you get, if you do drink a pint of beer, it doesn't taste like a pint of beer. You had this every 2 weeks. They then take a blood sample and check that to make sure that you're not being over-treated. And then you have another treatment after that time. Next week you'll have the treatment again, so it's every 2 weeks. And I had 5 treatments which did considerably shrink the actual tumour. It normally lasts about, depending on time, about 3 or 4 hours, but all the thing I got from it was boredom really, so take a book.
The chemotherapy wasn't anywhere near as bad as I thought it was going to be. It was pretty bad, the last part of it, but the first part wasn't too bad.
It did have a slight effect. I did get a slight infection in the leg, which may have been due to that, they said, but again, nothing to worry about.
My boss let me work from home whenever I felt up to working, you know, if I was fit enough to do it, because it does take a lot out of you, the chemo.
Over the period of 3 months, you had 3 major ones, and then in between each month you had 2 minor ones. The minor ones weren't so bad. The major ones really made you feel terribly nauseous, ghastly. But anyway, it had to be got through. You were having this poison put through your veins, and if it didn't, it had to kill the cancer.
Surgery to remove the bladder is called cystectomy. For the commonest type of bladder cancer, urothelial carcinoma or TCC, surgical treatment involves removal of the whole bladder, as well as some of the pelvic lymph glands and a part of the water pipe, the urethra. This procedure is called a radical cystectomy. In men, the prostate is also removed, while in postmenopausal women, the cervix and womb are removed together with the ovaries and part of the vagina. These organs, other than the bladder, are removed either completely or partly to allow a greater chance of complete removal of the cancer without cutting close to it. This improves the chance of cure.
The chance of cure with surgery depends on what sort of cancer is in the bladder for the person who's having the operation. In general, the chance of cure is higher if the muscle wall of the bladder is not involved, so-called non-muscle invasive bladder cancer. And for patients who have cancer in the muscle wall of the bladder, the chance of cure is lower. When cancer doesn't involve the main muscle coat of the bladder, so-called non-muscle invasive bladder cancer, the chance of cure with surgery is that between 60 and 90 patients out of 100 are likely to be cured with surgery to remove the bladder, cystectomy. And the chance depends very much on exactly what the sort of non-muscle invasive bladder cancer is and what the results from the laboratory show after the operation. When cancer involves the muscle wall of the bladder or goes beyond it, then the chance of cure is lower. And when the muscle wall is involved, between 60 and 70 patients out of 100 will be cured. If the cancer has gone through the wall of the bladder, then around 50 out of 100 patients will be cured. If the cancer has gone into the lymph glands around the bladder, then the chance of cure is that between 5 and 30 patients out of 100 will be cured by cystectomy or surgery to remove the bladder.
After radical cystectomy, because you no longer have a bladder, the surgeon must create an alternative way for you to store and/or remove urine from your body. This is called a urinary diversion.
The choice of urinary drainage after surgery, the plumbing options, is not an easy one. And in general, there will be the option of a urinary stoma or some kind of pouch, depending on your particular circumstances. There isn't a better or a worse option medically. They're different. They have different pros and cons, and they differ in terms of being simple and straightforward or not so simple and straightforward. And so making a choice is something that most people find quite difficult. Now, there are some medical factors that mean that one or other is not suitable for some patients. But when either a stoma or a pouch of some sort is possible, then we help people to try and make a decision in 3 ways. Discussions with medical staff, with us, discussions with specialist nurses and discussions with patients of ours who have had this kind of surgery, and offer their time to talk to patients who are considering the same kind of surgery. And most patients find that combination of discussions to be a good way of coming to a decision which suits them.
The different options are discussed in the following 3 chapters on the DVD, and there is further discussion in Part 2 and on the website. The most common urinary diversion is called an ileal conduit, where the surgeon separates a short section of your small bowel, or ileum, from the rest of your intestine and uses it to create a tube that connects the drainage pipes from the kidneys, the ureters, to one end, and the other end is brought out to a small opening in the skin of your abdomen. This is called a urinary stoma, or urostomy. A watertight bag is attached to the skin around the stoma and collects urine flowing from your kidneys. The bag is emptied several times each day, and a new bag is used every 1 or 2 days.
This is the area here that sticks to your tummy.